So welcome everybody. My name is Carla Treloar from the Centre for Social Research in Health, and it's a pleasure to welcome you to our World Hepatitis Day event to look through some of the highlights of our annual report of trends in behaviour. Of course, wherever we are across Australia, we're on Aboriginal land, always was, always will be. And I'm on the lands of the Bidjigal people of the Eora Nation, and I pay respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander colleagues joining us today. We put out each year our annual report in trends in behaviour, and we have one component focused on viral hepatitis and another focused on HIV and STIs. And the webinar for that is coming up next week. But today, it's World Hepatitis Day, World Hepatitis Week. We need to focus our attentions on our work in hepatitis B and hepatitis C. So we've got three fantastic speakers to go through today. I'll just introduce them all, and then we'll work through their presentations one by one, and we'll have about 20 minutes or so at the end for Q&A. So our first speaker will be Associate Professor Loren Brener, who'll be talking to some of our centre's work in hepatitis B. Following Loren will be Dr. Defeng Jane, who was wonderfully one of a PhD student working with Loren and I. And Defeng will talk about some qualitative work from her PhD about stigma and trust and hepatitis B. And then Dr. Lise Lafferty will follow up with a summary of hepatitis C content in our annual report in trends and behaviour, and then we'll move into some discussion. But if you want to put comments or questions in the chat as we go through, please do, and our presenters might be able to answer them while we go, and then we'll know where we're heading for discussion in that 20 minutes. So thanks everybody for coming along. I'm going to hand over to Loren to start.
Thank you, Carla. I'm going to do the screen sharing again, see that I can get it working. Can everyone see my screen?
Yes, Loren, can you just make it full screen?
Yes, Carla. Is it not full screen?
We can see the slides coming up down the side.
On the side.
You got to click to start the slideshow.
Thanks, Eleanor. How's that?
Yes, great. Go for it.
Okay, thank you. Welcome, everyone. Thanks for joining us today. I also want to acknowledge the traditional owners of the lands that we're meeting on today. I'm also on Bidjigal land, and I want to pay my respects to elders, past, present, and any Aboriginal and Torres Strait Islanders attending the meeting today. I'm going to talk a little bit about some of the stigma and attitude work we've been doing around hepatitis B. It's part of our broader National Stigma Indicators project. And we have, in the past couple of years, branched into looking at attitudes towards hepatitis B amongst communities that are impacted by hepatitis B. So today's presentation is going to focus on what's in the current annual report and trends of behaviour, which is knowledge, attitudes and understandings of hepatitis B amongst Chinese and Vietnamese people living in Australia. I can't resist, I have to tell you, we have new data coming up which focuses on the Filipino and Korean communities, and we'll be reporting on that in next year's annual report of trends in behaviour. Our first round of data collection with Hep B focused on Chinese and Vietnamese migrant communities, and these groups were selected because we know Hep B prevalence is high amongst these migrant communities. They're larger communities in Australia, and it was the first time we were doing this, so we wanted a group that we felt that we could access because we hadn't done research in this area before, and they were selected in consultation with our advisory group. So we collected data both using hard copies and online surveys. We had fantastic support from community and viral hepatitis organizations. Without them, we would not have been able to collect this data. And also, we had amazing support from our Chinese and Vietnamese researchers. Without them, we wouldn't have been able to collect this data either. They assisted in advertising the survey, checking translations, and communicating with various groups and networking for us. So we had surveys in simplified or traditional Chinese, Vietnamese, and in English. So this is just a breakdown of the samples that we got. So we landed up with 997 people from the Chinese community and 966 from the Vietnamese community. And just what's of interest and importance in this data is that the majority of participants were born in either mainland China or in Vietnam. So we were looking at people who are kind of first-generation migrants to Australia, predominantly. So we asked some questions around knowing people with hepatitis B and receiving hepatitis B information. And what we found was that 51.5, almost 52% of the Chinese and 36% of the Vietnamese community reported that they knew someone living with Hep B. 88% of Chinese and 90% of Vietnamese community participants had received some kind of information around hepatitis B, and the most common source of this information was the internet. In terms of testing for hepatitis B, almost 73% of the Chinese and 64% of the Vietnamese community had ever been tested for Hep B. The main reasons given for testing was it was part of a regular health check, or the doctor had recommended it. Almost 70% of Chinese and 75% of the Vietnamese community said that they were satisfied with the information that they were given about Hep B at the time of testing. What's interesting are the reasons people report for not being tested for Hep B. So among the 200 Chinese and 203 Vietnamese participants who hadn't been tested, they reported feeling quite well. And this comes up a bit in our data that there's a lack of awareness that hepatitis B can be asymptomatic. And so people, if they're feeling well, don't think it's necessary to be tested. They also didn't know about testing. They were afraid of having a test. And among our Chinese participants, 79 participants reported that they had not been tested because a doctor said they don't need to be tested. So in terms of vaccination for hepatitis B, 60% of the Chinese sample and 63% of the Vietnamese sample had ever been vaccinated for hepatitis B. What's interesting is that the majority reported, 83% of the Chinese and 84% of the Vietnamese community reported that they had received the full course of the vaccination, which is really important. And the other interesting thing is that of this group, although the majority were born outside of Australia, 41% of the Chinese community and 56% of the Vietnamese community had received any of their doses in Australia. So now just looking at some of our data on attitudes towards hepatitis B. Our participants were asked whether they would experience stigma or discrimination if they had hepatitis B. Among the Vietnamese community, almost 20% said that they thought this would happen often, and 3% felt that it would happen always. And among the Chinese community, 14% felt that this would happen often, and 3% said that it would always happen. We asked some other attitude items about feelings towards people living with hepatitis B, and responses were quite mixed, as you'll see. So 64% of the Chinese and almost 65% of the Vietnamese community felt that people who have Hep B should not be isolated by family and friends. However, 32% of the Chinese and almost 34% of the Vietnamese community reported that if they knew someone had Hep B, they would avoid close contact with them. 53% of Chinese people and 53% of the Vietnamese community felt that screening or testing for hepatitis B is necessary for job applications because it's helpful for preventing transmission to other employees. 33% of Chinese and 41% of the Vietnamese community sample said they would not have a romantic relationship with someone who has hepatitis B. And almost 12% of Chinese people and 17% of the Vietnamese community felt that people who have hepatitis B should be ashamed of their illness. So in terms of knowledge of hepatitis B, this is important because this can fuel fear and negative attitudes. And we found mixed knowledge, and particularly knowledge about causes and transmission was low. So 73% of the Chinese and 85% of the Vietnamese community knew that there's a vaccination that can prevent Hep B. But only 36% of Chinese and 26.6% of the Vietnamese community were aware that there was an effective pharmaceutical medications available to treat Hep B. 77% of Chinese and 88% of the Vietnamese community knew that Hep B was a virus. However, many participants incorrectly thought that Hep B is caused by a damaged or weak liver, drinking too much alcohol, or contaminated food, water, or other utensils. And around 2/3 of both samples incorrectly thought that someone can prevent getting Hep C or giving it to others by exercising, avoiding sharing eating utensils with someone who has Hep B, making sure food or water is not contaminated, and maintaining good hygiene. So just some concluding points around this sample. What we see is that many people reported knowing someone with hepatitis B, and most had obtained some information on hepatitis B. For both samples, more than half had been tested for Hep B. Feeling well, not knowing about Hep B tests or being afraid were the main reasons people didn't get tested. Around 60% of both samples reported that they had been vaccinated for Hep B. Around 20% of both samples believed that they would experience a lot of stigma and discrimination if they had hepatitis B. And while participants felt that people with Hep B should not be isolated by family and friends, their other attitudes that we discussed suggest that they feel a need to distance socially from people with hepatitis B. Knowledge was low, and this also suggests that any negative attitudes that people expressed can be driven by misinformation and fear around hepatitis B. And just thanking everyone involved in this project so far. And we will have upcoming new data next year. Does anyone want to ask any? I suppose there's time at the end for questions, so I'm going to hand over to Defeng.
Hi, everyone. My name is Defeng from the Center for Social Research in Health, University of New South Wales. I pay my respects to elders past and present and acknowledge the traditional custodians of the land that I'm on, which is the Wiradjuri and Balaram peoples of the East Kulin Nations. Very pleased to present my PhD study, Hepatitis B-related stigma and trust in healthcare providers among Chinese immigrants living with hepatitis B virus in Australia. First of all, I'd like to give you a brief introduction to the background of this study. Chinese immigrants in Australia are overrepresented among people living with hepatitis B virus. However, they experience poor access to healthcare. In mainland China in 1990s, laws were enacted which discriminated against people living with hepatitis B. Although these were repealed in 2005, this institutional discrimination has shaped the experience of people living with HBV. Based on this background, the study explored the lived experience of stigma and discrimination surrounding HBV among Chinese immigrants We also tended to explore participants' interactions with physicians and alternative practitioners, focusing on their trust in healthcare providers. The study recruited participants who were adults living with HBV, having been living in Australia for over 6 months and self-identified as of Chinese descent. All participants provided informed consent and received a $20 gift card. Ethical approval for the study was obtained from the Human Research Ethics Committee, University of New South Wales. The study was advertised through advocacy groups and hepatitis education events hosted by Hepatitis New South Wales and Hepatitis Victoria. To engage the broad community, we created a bilingual website and an official account on WeChat, which is the most popular social media platform among this population. From 2019 to 2020, 16 semi-structured interviews were conducted in Mandarin or English by a researcher with a Chinese background. The interviews were conducted face-to-face or over a phone. Face-to-face interviews took place in community locations. All interviews were recorded, transcribed, de-identified, and translated into English where necessary. The data were processed with NVL12, and the analysis was guided by reflexive thematic analysis method. The 16 participants were aged between 40 and 75 years, predominantly women. All were diagnosed in China. The time since diagnosis ranged from 5 to 47 years. 14 of them were engaged in healthcare at the time of being interviewed. Data analysis on HBV-related stigma was informed by the Health Stigma and Discrimination Framework. Participants' accounts in the interviews showed that HBV-related stigma was mostly driven by a lack of HBV knowledge and food customers that value sharing food. Exclusion from family and social meals was the most frequent form of stigma experienced by the participants. HBV-related stigma manifested in a range of ways, including separating from family, separation by family, reduced prospects of a relationship associated with sexual promiscuity and employment discrimination. For instance, a participant described her experience of seeking a job in Sydney a few years ago. That position was a part-time job at a childcare center. It was my ideal job. After several interviews, I was accepted and required to take a medical examination. But I was so scared that I didn't go for it. I gave it up. Another theme emerged from the data was intersecting stigma. In the Chinese context, HBV-related stigma interacted with those stigmas associated with occupation and socioeconomic status. While in the Australian community and healthcare encounters, participants experienced multi-layered stigmas, including racism. For instance, a participant perceived insufficient resources allocated to HBV healthcare. He said, "It is reasonable to say that the government should give this more importance. The prevalence of hepatitis B among local Australians is not too high. It is more common among Asians. There are fewer resources available. The service in this regard is also relatively poor." Now moving on to the findings on trust in healthcare providers. The model of trust proposed by Hall and colleagues was employed in the data analysis. The conceptual model consists of 5 dimensions: fidelity, competence, honesty, confidentiality, and global trust. This table shows themes generated in each domain, with the domain of fidelity, which means healthcare providers care about patients' medical needs and avoidance of conflicts of interest. Themes developed or perceived providers' attitudes and discouragement for participation in decision-making. With the domain of competence, there were 5 themes such as perceived providers' medical techniques, interpersonal communication techniques, and inadequate HBV information provision. Some Western physicians were perceived as narrow-minded in acknowledging complementary and alternative medicine treatment as available options, generating hostile patient-doctor relationships. When looking at the broader interactions within the health system, the challenges participants faced in navigating the Australian health system were related to the perceived inefficiency of mainstream healthcare. As noted by a participant who had lived in Australia for over 20 years, people living with HBV often faced poorly coordinated and fragmented care. Financial disadvantages could also hinder access to timely health care. In conclusion, I want to highlight that historical institutional discrimination, Chinese food traditions formed a cultural context that influenced how Chinese Australians thought about hepatitis B. The essence of the stigma surrounding hepatitis B was fear of the health implications of living with HBV among family and the community. HBV-related stigma interacted with stigmas associated with social status, occupation, migrant status, and ethnicity. As a result, the participants' positive health and well-being outcomes, economic opportunities, prospects of intimate relationships, and community engagement were limited. We recommend a multi-level holistic approach to address HBV-related stigma and intersecting stigmas to improve social inclusion and health outcomes of Chinese people living with HBV. In terms of trust in healthcare providers, the study showed that it was formed and influenced by various factors, including patient-provider communication, pre-migrant relevant experiences, health and illness beliefs, and systemic barriers. Our findings suggest that physicians can increase patients' trust and healthcare engagement by treating them with respect, improving interpersonal skills and cultural competency, and having open discussions on complementary and alternative medicine treatment. And last, I'd like to finish with thanks to all the participants and support from these organizations. And finally, thanks to my supervisors and the funding from the University of New South Wales. Thanks.
Thank you, Defeng. So great to be able to highlight the terrific work that you did in completion of your PhD. And apologies, my Zoom dropped out a little bit there. So handing over to Lise to take us through some hepatitis C research.
Thanks, Carla. I'm going to just continue my tech nightmare of the day.
Looking good.
There we go. Okay. I've got some weird view of people. There we go. So I just want to start off. I'm on campus today, and so I want to pay my respects and acknowledge that I'm on Bidjigal land of the Eora Nation, and pay my respects to Aboriginal elders past, present, and emerging, and anyone who may be joining today. So I feel like I'm going to be a bit of an auctioneer, just barreling down, shouting at everybody about what we've done. Jake and I have met and went through the hepatitis C section of that annual report, and we picked out a few key different papers to highlight within this. And so I feel like I'm just going to, run through it. I've got 20 minutes to cover, I think, 10 studies. So I'm not going to be talking much about methods or theoretical frameworks, because that all falls by the wayside when we're in a hurry. Here we go. So just quickly, we changed the themes of the layout of the report from last year, previous years. And so this year we've broken it down into harm reduction and the AOD sector, prison setting, and then lastly focusing on sort of that care cascade, treatment, elimination, cure. And just, for fun, I've flipped it up in the presentation. So I'm going to start with the prison setting. And these are the 3 papers that I'll be speaking to. So the first one draws from the PIVOT study, and it's around hepatitis C RNA point of care testing within a reception prison in New South Wales. And so we wanted to understand what people thought of it. In a reception prison, you would think people have a lot going on in their head. And so we wanted to know, was testing for hepatitis C at that intake period, that first week, going to be too much of a burden, or was that going to be okay for people? And people really described feeling quite good about it. Actually, it was done straight away. They got their results the same day. And so that actually alleviated some of those issues for them. And someone here talked about, this bottom quote talked about, he got tested here, sent down from another prison in a past experience. They'd lost their paperwork. He had to do all the tests again. Then he got moved to another prison again. And so that prison setting that we always describe as, is a highly contained environment is very much not a contained environment, and there's a lot of movement. And so standard testing can be really challenging for people. So doing point of care testing really was able to put this person onto treatment, whereas they hadn't been able to do it in many years previously. So it also reduced the psychological burden of awaiting for test results. So they weren't sitting around doing head miles, as this person says. They got their results the same day. And so it alleviated that psychological burden of wondering whether you've got it or not. So just quickly, broad levels of trust in the testing process. People really thought they were getting accurate results. People preferred finger stick testing over venipuncture. And that was we interviewed people who had a history of injecting drug use, as well as people who did not have a history of injecting drug use, along with people who had previously been tested for Hep C and those who had not been tested by venipuncture. So people who had bad veins due to drug use or were afraid of needles, they really found this finger stick option a positive. Moving on, this is talking about the STOP-C study. So hepatitis C treatment as prevention in 4 prisons in New South Wales. And this paper is called You Need a Designated Officer. And I'm just going to highlight a few key points about the role of officers in a treatment as prevention program. So this person explains it should be externally funded. Because the university is paying for this, they can't relocate that officer that day. If there's lockdowns, if there's a shortage of staff, that officer, regardless, is going to be designated to that hepatitis C position. And if they don't have that designated externally funded position, this person explains it's doomed to fail. And then officers should be carefully recruited. This was a really important part of it. And so I've got videos that I can't see what my quotes are. This person explained it was a senior administrator that in recruiting the STOP-C officer at that prison, she's keen, she wants to play a part in it. They're caring and they come across to the person as caring. So in terms of going out into the prisons and trying to get people to come forward for testing, it was really important to have someone who cared. And also that designated officers could be tasked with cultural change. This is a really key point in any sort of cultural shift that might happen in a prison, particularly around hepatitis C and that stigmatized virus. So you need a designated officer. Other officers can become defensive, wondering, why are you treating an inmate? What are you giving to us? And so there was a real concern about that within the prisons. And this officer explains, I talked to both sides. So being able to communicate effectively to people in prison, but also to the other officers, and navigating that health correctional officer fine line. This is a commentary here that was done regarding the harm reduction reference group. This was published in 2020. They're all published in 2022. And one of the joys of doing the summary today for me has been able to go through and read through, word for word, every paper that we reported on in this report. And so I found this a great paper in that it was just this wonderfully written, straightforward summary of why we have such high prevalence of Hep C in prisons, and talking through that, there's no provision of needle syringe programs, which of course is increased likelihood of equipment sharing, which then leads to the higher risk of transmission. So I really thought it was really well written in explaining that. So if you're ever looking for an easy to read background, I suggest this paper. And they also go on to explain the competing priorities of security. So correctional officers not wanting to support people who to inject drugs in prison, where that might be illegal, but also perhaps perceived as unsafe. Whereas then you've got the role of health, who are there to, they want to reduce transmission of an infectious disease. So it's that conflict that's happening in the prison setting. And so the paper goes on to explain the development of the Joint Harm Reduction Reference Group, which was initiated by both Justice Health, who's tasked with running the prison health in New South Wales, along with Corrective Services New South Wales. And it comprises 20 members, including both Justice Health, Corrective Services, non-government organizations, and public health experts and academics. And they've really achieved two examples of some great things. The first being a statewide audit of accessibility to condoms, dental dams, and FinCool, so access to harm reduction. I think it's important to point out that there's a difference between what's available and what's accessible. And so that's a real problem in prisons, is that you may have FinCool, which is a type of, not quite a bleach, but it's what's used for cleaning, injecting equipment in prisons. But if it's right next to the officer's station, I would argue that's not very accessible. And so they did this audit to determine that. And then what came out of that audit was 11 recommendations, including confidential reporting by people who are incarcerated when access is hindered or unavailable. So being able to put that forward and get that corrected in their prison. And then they also came out with changing language in policies. So changing from should be available, we can all have that dream that it should be there, but it must be available. So that's a pretty critical point in terms of access to harm reduction in prisons. So now moving on to the next section. I hope everyone's staying with me as I'm flying through all of this. So we've got just two papers in here that I'm going to highlight today. So the first one is the term aftercare, and this is another great paper about, and it's a commentary, so it causes you to think, and I think it's a great reflection of the wonderful thinking that is done at CSRH. But so aftercare refers to service provision, which occurs in the period after intense service engagement. So perhaps someone goes to rehab, and then it's that, once they exit rehab, it's that care that's happening after the exit of rehab. But it is also thought of as that occurring after the real care. So the rehab may be deemed as the real care, but then, what about the rest of it? That's not, life is not resolved when people exit different care programs. And so many people in the paper, it describes that many people may cycle through AOD treatment with different drug use experiences over several years. And so aftercare fails to recognize those diverse, complex needs of people as they exit AOD treatment and in that follow-on care happening. And so they suggest the term continuing coordinated care, which I think really does better capture what's happening for people and causing services to be more responsive to those unique needs. And then here's a paper, and I feel very strange because I'm reporting on work that other people have done. So this is Loren's work here, who's led this paper. And so this was a mixed method study that was done between, as we can see, the survey was done between July and December 2020. So, if we put our head in that space of what was going on during restrictions that year, and then interviews were conducted in September to December of that year. And so it's about healthcare workers' experiences and perceptions of delivering care in that time period during those intensive restrictions in that first year of the pandemic. The survey findings, and this is stolen from the paper, so you can all access it quite easily if you're interested to read more. But I think broadly, people felt that they weren't any more likely to contract COVID from clients than they were from anywhere else in their life during COVID, during that period. People felt that about half felt that the service had implemented enough changes to help clients during restrictions, whilst a third thought more should be done. And then, standard, I think we're all familiar that the most common changes done were client wellness screening. We all can remember walking through a front door somewhere and having to get your temperature taken, the forehead thermometer, increased outreach by telehealth. We've all had those GP appointments, I'm sure now. Enclosing gathering spaces, and I think this is really important for AOD services where people might have had a hangout room and then that was, taken away during this period or incredibly reduced. And so there may have been those limited interactions happening on site, as well as provision of takeaway fit packs. And I think I kept the quote in where I feel like that's really relevant. So we'll get to the qual in a moment, but perceptions of level of risk of contracting COVID at work. So I've messed that one up. That's not actually right. But current relationship with clients was the same as pre-COVID. So 2/3 thought that. But others believed that they weren't getting enough face time or enough attention, that they weren't being able to have that right connection with clients. Whereas, another third didn't want as much face time. And so people were navigating, healthcare workers or harm reduction workers were navigating the complex time that was that everyone was going through. And I think really strongly trying to meet client needs, but also trying to meet their own safety needs as well. And nearly half felt there was a greater divide between staff and clients, which we can imagine in those circumstances there would be. So qualitative findings, some negative impacts on rapport. And so this person's describing, Jamie's is describing someone coming through, they're rolling their eyes. This is the third time today I've had to get my temperature done. Like we know I don't have COVID today, right? And so that can really hinder on rapport building with clients. But on the flip side, and this is that sort of fit pack comment and the provision of harm reduction equipment is that, a lot of places were just putting it out. And so people were able to grab what they needed without having to be so accountable as perhaps they had been pre-COVID. And that shifted the manager's perspective from Indigo's standpoint. So what if they grab everything? That's what it's there for. So I think that was a really great positive thing that came out of this research to show that. Okay, my last session. I can't get the word right today. I feel like Kari needs to explain this to do it good justice, so I'm going to have a crack at it. So this one is around, it was a real critical analysis of the different messaging from the No Hep campaign as part of the World Hepatitis Alliance. And in the commentary or the research from Kari and Tim, this really talks about getting us to think critically about how the messaging is laid out. What does it mean in the future? How far is that? Where is the goal? What is the goal? And if we look at the racetrack to the right, this is probably the best example that I can articulate from the paper, was around, if we look at, and I know it's very small, so I'll try and read out a little bit of it, but you've got Hep B diagnosis, Hep C diagnosis, Hep B treatment, Hep C treatment as your bottom 4 bits there on the racetrack. And so is everyone trying to get to the end goal at the same time? What happens if we get to Hep C treatment reaches there first and we've really achieved that treatment goal, but the others are lagging? Are we achieving elimination if that's happening? So I think it's a great paper for questioning how we're thinking about what's ahead and how do we get there. A gender lens. I just want to point out, because I think this is fantastic, the stellar author list on this commentary. It's a really great piece of work that reminds us that how important it is to consider the role of gender when we're talking about hepatitis C, when we're talking about access to testing, treatment, to OAT services, which is a big part for some people about accessing hepatitis C care as well. And there's a lot of barriers that can be there. And I know, as someone who's done research in prison, I know that there's huge amounts of stigma for women in prison, particularly around fear of child removal, stigma and discrimination, and turning up somewhere, trying to access care, and then being told, what a shitty mother you are. And so I think this paper really strongly points to that and how important it is that we keep that at the forefront as we engage in research around Hep C and OAT and what is access. And also we often talk about, the paper points out that we often talk about is prison is, people may prefer to access hepatitis C in prison. And so that can be a place where we might focus some efforts for hepatitis C care. But however, that's actually, women are being done a disservice in that approach sometimes because they have lower incarceration rates than men and they have shorter lengths of stay. So often women may find out in prison that they've got Hep C, but depending where they are in the world, that might make them ineligible if they're going to get released prior to their treatment end date, where that continuity of care from prison to community may not be so great. This is work led by Alison Marshall. This is from the Ethos, I believe it's from the Ethos Engage study. And this is I really enjoyed this paper because we always talk about the care cascade and it always seems so straightforward and wonderful and just, and now we've streamlined things and everything's so much easier to do. And so Alison had done a bunch of interviews with people and then purposely selected, I think it was purposely, 5 interviews to focus on. So 2 people who had disengaged in care after an RNA diagnosis, so after current infection. And then 2 who were housed at the post-treatment pillar. We're going to call these pillars, the little graphs, the bars. And 1 person who received treatment who has a dissenting case. What this paper highlighted to me so much as I read it is that phrase of there are no hard to reach patients, there are only hard to reach services, because the complexity that people in this case study identified of often it wasn't just about turning up, and you do the 1 visit and you go away and you come back for your next and go away and then boom, you've managed to get through the care cascade. And it's been a huge challenge for a lot of people to be able to make that progression. And I think there's a lot of blame that happens in the health system around assuming that we've made it all accessible and easy and straightforward and make your appointment and turn back up, or a drop-in service turn up and then it's there for you. But a lot of the scenarios that were relayed in this paper were people having to fight to get to those services that were supposed to be quite straightforward. I think it's a great paper if you want to better understand about the actual experiences of engaging in the care cascade. This is my last one. I think I might have even saved time on this. This one is led by Kylie. It's part of the My Health, Our Family. So it's about serodiscordant families. And so these interviews were done with healthcare workers. And in the very first sentence of this paper, I thought it was great. It really struck me. A virus has a social history. And this healthcare worker is describing their experiences of working with people with HIV, Hep C, and hepatitis B. And so clients have wanted to actually say they've got cancer instead of saying they've got Hep C or HIV, because people will accept them. They'll provide all sorts of different support for them. If they told somebody they've got a bloodborne virus, they could potentially be rejected because people have a fear of those viruses. And it struck me, right? It highlights the ways in which the social histories of a virus can be so stigmatizing and be so damning and continue to have harm in and of itself in the way that people respond to them. And I just want to end on that note of stigma and talk that we've got another seminar next week for the other component of the annual report of trends in behavior that's specifically looking at HIV and STIs that Martin Holt will be talking about, and then Kim Brody will be talking specifically to stigma. Thank you.
Great, thanks so much, everyone. Loren, Defeng, and Lise. Terrific overview of a whole lot of different things. In the chat, I've put the links to the various papers. They are mostly behind paywalls. That's the business model of academic publishing. If you would like a specific paper, you're most welcome to email me. I'll just put my email in the chat. But now we're open for discussion and conversation. So while people are getting their thoughts together, you're most welcome to raise your hand and or put a comment in the chat. Defeng, I wanted to ask you, your two papers focused on stigma and trust. So we talk a lot about stigma and hepatitis B, but I wanted to dig a little bit deeper into your interest in trust in medical professionals and the medical system. Can you tell us why you thought that was an important aspect to explore in people from Chinese background living in Australia with hepatitis B?
Thanks, Carla. I myself from mainland China, and I know a little bit about the health beliefs among Chinese people. And I conducted a literature review to develop the interview guide before conducting interviews. So during that process, I got some ideas about the challenges and difficulties in communications with physicians in healthcare encounters. So I thought that it would be worthy to explore further and to see what the situation is in the Australian context.
Terrific. Thank you, Defeng, and nice comment, Jack. Thank you. Appreciate you being around and hanging around. Lise, picking up on the first papers you mentioned, one of your own about point of care testing in prisons. I'm not going to quiz you on papers that aren't yours. Point of care testing, people talk about it as the next big thing, the silver bullet. In your exploration in prisons really showed the complexities of implementation. Are there other things you think we could wrap around understandings of how point of care testing works that we need to explore some more?
In the prison setting?
Yeah, let's talk about prisons.
Look, the Combi Clinic is doing a fabulous job of going in and doing these high intensity testing campaigns. But I think it's a model that worked very well for them, and they've been given lots of access to the prisons, whereas I think most places you've got to come to the clinic. And I hear various, is Hep C the stigma that people don't want to talk about, or is it being someone who injects drugs? And that stigma seems to shift every year or two. It doesn't seem to be a balance that stays stable. So I would think that if there were ways to get out into the prisons rather than people having to come up to the clinics and being able to go out into where people are and do more discrete testing would be an ideal approach.
Yeah, I know if there's someone here from Justice Health, there's a dry blood spot program where that can go out and not have to sit in the clinic.
Which takes 2 weeks, which can be a problem for people.
Yeah. Someone on iPhone 2, Loren, do you want to jump in on that? No, something else? You go.
I wanted to talk about something else completely. Back to the Hep B work. I'm just sorry, Lise, to go back to that. I just wanted to talk about the upcoming work because I think it's important just to talk about what we will be hopefully publishing in the next few months. Within our sample of Chinese people, community attitudes, we also had 220 people who are living with hepatitis B. So that will be really interesting data. And I think it's a really big sample of people living with hepatitis B that we'll be able to talk about soon. And the other thing is just to mention that with the Filipino and Korea data sets, we have about 600 surveys from each of those communities, and the trends are similar to what we've seen with the Vietnamese and Chinese communities. That data will hopefully be available in the next 6 months. So just look out for that information when it comes through.
Yeah, that would be really interesting. I think the largest sample of Chinese people living with hepatitis B that we've seen in a survey. That's fantastic. There's a comment in the chat, I think only to me, about access to care in rural health settings, difficult to accommodate for Hep B and C, and clients don't want to travel. I think we can all nod our heads to that and indicate. And E. Williams advising about point of care, trying to get point of care testing in South Australian prisons, though not approved through TGA as yet. Special programs to be able to do it, and hopefully granted access generally soon for delivery throughout the whole prison system. Loren, is there anything, sorry, Lise, is there anything else you want to comment on that? Or E. Williams too, do you want to jump in at all? Lise?
I just think that sounds fantastic. I know some prisons are keen to do it nationally, but it's about getting the right program that allows them to do that until TGA gets through.
Yeah. And also talking about a mobile service for remote locations, and there's been a terrific service that NUA, the drug user organisation in New South Wales, has run, Peers on Wheels, POW, taking their van out to various settings outside the centre of Sydney and across regional locations in New South Wales. So if you're interested, contact NUA to find out more about that. So E. Williams, I can see you've turned your camera on. Do you want to say some more? Sorry to call you E. Williams. It sounds so very formal.
Hang on, just having issues finding the turning my unmute off. No, just and apologies if I got that wrong and it was New South Wales and not Queensland, because there are some great mobile services, and we literally, I've been at a meeting today, the model of care meeting for our viral hepatitis nurses here in South Australia, and it's a problem reaching people and keeping them, losing them to follow up with both Hep B, Hep C, and HIV actually. Because there are, we've got these clusters and we're so remote. I mean, every state is remote, but there needs to be, we have to be thinking outside the box to reach and be able to effectively care for people within our system. And I think one of the only ways to do that is to go out to where those people are. It seems to have worked really well. And you're right, the POW, that was great. I saw them present again at the conference in Brisbane. Fantastic.
Yeah, great name too, right? All the power, terrific. Yeah, taking services to where people are at. I know there was a comment before about the difficulty engaging with people homeless or experiencing other marginalisation situations, and where the cascade of care is almost impossible at times. So bringing that cascade closer to where people are, literally and figuratively, is something we can see with those mobile services, and with efforts to bring prison testing out of the clinic and into the yard, even in a small location mobile. Loren, I wanted to come back to you about the data you had about the high proportions of people who, in the Chinese and Vietnamese samples, so these are general population, Chinese and Vietnamese background, who thought they would experience stigma if they were to live with hepatitis B. So really high proportions there. So these are people not living with hepatitis B, but thinking if they did, experience stigma to quite an extent. Have you got some more insights to talk on about that?
Well, I think it ties in with what Defeng said, and a lot of Defeng's presentation about the fear people have around hepatitis B. I think some of our qualitative work also suggests that it's really around misinformation that people have, and low knowledge, we could see in the survey. But that people really feel that that Hep B can be transmitted by spitting or by sitting next to someone with Hep B. That's come out in some of the qual work we've done. And so I think that's what informs a lot of the attitudes that people have towards those living with hepatitis B. I think the interesting thing that Defeng touched on is the food culture amongst Chinese people in particular. And I mean, Defeng could speak a bit more about that, but I think from what I understand, there's a lot more that goes into the preparation of food and eating together, and that might be a particular concern for these communities. I mean, Defeng, have you got anything to add to that?
Thanks, Loren. Yes. Misinformation and historical discrimination against people living with hepatitis B. I think our studies have found the significant influence of these factors, even though they have been lived in Australia for example, for decades, but the fear is deep in their mind and it's hard to change.
Yes, the legacy of those experiences have a long tail on them, a long lag. Limin Mao has just dropped into the chat the link for our next ARTB, Annual Report of Trends in Behaviour seminar next week, which is on HIV and STIs for those who are interested. So we're just about at time. I really want to thank our great presenters today, Loren, Defeng and Lise, for taking us through a big range of data. And also to say, you know, the door is always open. Please contact us if you want access to this research or you want to talk about the findings and discuss how they might be useful in your settings. We're always really happy to do that, have those connections and have those conversations. So please use this as an open invitation for people to get in touch. Thank you very much for coming, everyone. Thanks to the fantastic team at CSRH who puts all of this together, Eleanor Karma and Limin Mao in our team. And we'll see you for next World Hepatitis Day, and happy World Hepatitis Week to everyone who's doing lots of different activities across the country. Thanks, everybody.